I have four last things to say, and that's the first, that if we had our druthers, if we had what we would rather do, I would rather not treat people with medication for a thing like high blood pressure. I'd rather prevent it in the first place. So I poked around on the internet and I said to myself, who's done a recent study of blood pressure prevention? And I came across this first hit when I put prevention, hypertension, and a review article into our PubMed, our National Library of Medicine. And this particular study here, diagnosis, but you can read it for yourself, from Defoe, Kouate, and others, is from Cameroon. And I'm going to read just a piece of this slide here. And I can't read it all because I've got this thing sitting on the right-hand side of my screen that blocks a little bit of the print here. But what it says is this: the highest blood pressure levels in the world have shifted from high-income countries to low-income countries in South Asia and particularly sub-Saharan Africa, while blood pressure levels have remained consistently high in Central and Eastern Europe. The global prevalence of raised blood pressure in adults aged 18 years and older was 22% in 2014, but Africa is well above that worldwide mean, running around 30%. And here's the punchline. By and large, published international and World Health Organization guidelines are unsuitable in their application in many ethnically diverse populations of countries in sub-Saharan Africa because of a variety of reasons, including ecology, sociology, and healthcare environments, poor infrastructure, and hindrances to promoting lifestyle, and in some cases, unaffordability of the costs of care for patients. And that impedes the incorporation or the adoption of recommendations for lifestyle and drug treatment. Good quality data on hypertension in different ethnic populations in much of sub-Saharan Africa, and here's the ouch, I was part of JNCA, so I am guilty of this. In much of sub-Saharan Africa are notoriously missing in the treatment guidelines, which are largely based on white populations, whereas cardiovascular disease varies, cardiovascular disease prevalence varies with ethnic origin. Of the more than 180 studies that met the standards of 8th National Joint National Committee reports, fewer than 30 were from non-white, non-African American groups. This is true. Guilty as charged. From a lifestyle standpoint, beyond prevention, so prevention can't keep people from getting older, but we can recognize that within the constraints of the population and what is available, there are some things we can do. And that leads us to what can we do, short of prescribing a medication. Probably one of the best worldwide is the reduction in sodium intake. Achieving and maintaining a weight appropriate for your height and waist circumference. Having a reasonable exercise pattern. You asked, we recommend 30 to 45 minutes of something, some dedicated activity, at least 5 days a week. And at least from a public health standpoint, a reduction in alcohol intake, but not complete abstention, not complete temperance from alcohol. Also will provide a couple millimeters of blood pressure reduction. I put some data in here just to give you a sense of how much effect that has. For example, if we were to adjust the sodium intake in the population from worldwide average around 3,400 to 3,800 milligrams of sodium per day down to around 2,400, we would get something like 4 to 5 millimeters of blood pressure response worldwide. And since that Gaussian peak of blood pressure distribution centers near the point at which we typically diagnose high blood pressure or pre-hypertension, moving that curve a little bit to the left can have huge import from a public health standpoint. The third of the 4 points is drug therapy. And here I'm going to just give you the 2 take-home points rather than go through each of these particular agents, how to use it, how to titrate it, how good it is, how bad it is, etc. Worldwide, the thing I learned traveling in Africa, in Asia, and Europe, and Latin America. So I've been fortunate enough to visit many countries around the world through medical missions from the US. Probably one of the most effective and least metabolically costly agents to use is a dihydropyridine calcium channel blocker, such as amlodipine, because it lowers blood pressure in most populations. And if you use a drug, this is one that doesn't raise blood sugar, doesn't usually impair potassium concentrations, doesn't affect cholesterol, and doesn't influence kidney function. So it's one of the less complicated drugs to use, and it is available and it's long acting and it's generic, at least in many parts of the world. But no matter which medication you use, whether you attack the salt arm with a diuretic, the autoregulation arm with a calcium channel blocker, the humoral arm with something blocking the renin-angiotensin system or aldosterone, or the adrenergic arm with one of the sympatholytic type medications. Whatever you use, if you need a second agent, the first take-home message is pick something from a different part of this quadrangle. You started with a calcium channel blocker, add an ACE or an ARB to it, rather than another drug working solely on autoregulation. Remember, these four things conspire together to raise blood pressure. And if you address one, sometimes that leads to reflexes in the others. So diversifying your portfolio of blood pressure medications is useful. The second take-home message is that if you have a manufacturer's dosing range of, say, 10 to 40 milligrams, of a particular agent that you're using to manage someone. If you hit the center, the 20, for example, 10 to 40, around 20, because it may come in a 10, 20, and then you give 2 20 milligram tablets. When you hit the 20 milligram, you've got about 85 to 90% of your effectiveness. Somewhere in the middle of the range of doses you can use for most medications is the sweet spot in terms of effectiveness. And if you keep going to the max of that drug, you don't get much more in the way of efficacy, but the second take-home point is you do get more in the way of side effect. So at least in the US, we tend to use a philosophy of blood pressure medication that picks a drug, titrates it to the middle dose. Did it work? Seems to work, but I need more. Then we add a second drug rather than going to the maximum dose because it cuts down on the side effect profile. And in some cases, you can actually leverage some of the side effect profile. For example, the hypokalemia, or the reduction in potassium levels from a diuretic by the use of an ACE inhibitor or an ARB, which mitigates some of the hypokalemic effect. The last thing I would mention is that one of the things that's on the radar, at least for the future, is the use of therapies that may not require drug or lifestyle modification. This is just one example of a recent publication in the Lancet on the use of renal denervation to manage blood pressure. It's not available worldwide, but it is available in, well, at one point, the Simplicity catheter was approved in 88 countries around the world. So the technology has been at least introduced in many places. It's not, at this point, in my mind, ready for prime time and first-line usage. But I think that just keeping our eye on the ball and looking to the future, one of the things that could be in our future is the use of devices, whether it's denervation of the kidney, coupling of an artery and a vein through a fistula, a disc that stimulates nerves under your wrist, and a cage that goes in your carotid. There's all sorts of clever devices going on, clever approaches with devices going on in different parts of the world. So stay tuned, because I think the future has kind of got some promise for some interesting outcomes in the not distant future. So here's what I've said, and I largely based the global impact portion of this from a talk that my good friend Brent Egan gave 2 weeks ago at the American Heart Association's Council for High Blood Pressure Research meeting. Bottom line, the health and economic burdens of hypertension don't adjust away. The world's getting heavier. Our access to excess is a problem. The prevalence of hypertension is growing, and our ability to control it is not keeping up with the rate at which it's growing. We need good prevention strategies and acknowledged blood pressure goals in order to overcome this.